Good morning and welcome to my YouTube channel. This is Mr. Dibo. This morning I want us to discuss a question on head injury. If you are new, subscribe on my YouTube channel, Mr. Dibo class. So let's look at the question we want to discuss this morning. So here Mr. Ken comes to a ward with a diagnosis of head injury sustained from RTA. So number one, they are saying stage 2 major injuries. Then part B, they are saying explain 5 possible investigations. And part C, they are saying discuss the management of the patient under the following headings. So number one, they are saying medical and surgical treatment. Then number 2, they are saying nursing care. As well as on part D, they are saying explain 5 complications of head injury. So let's start with part A. On part A, they are saying 2 major brain traumas or injuries. So the first one, it is contusion. Now contusion, it is simply the bruising of the brain tissue within the focal area that maintains the integrity of the paired matter and the arachnoid layers. So it usually develops areas of necrosis, infection, hemorrhage, and edema. So it occurs at the site of a fracture. Okay, or in short, COP type of injury. Then you also move to the second one, which is lacerations. This one involves the actual tearing of the brain tissues and occurs frequently in association with a depressed and compound fractures and penetrating injuries. So tissue damage here is severe and surgical repair of laceration is impossible because of the texture of the brain tissues. So no surgery can be done here. Then part B, they are saying explain 5 possible investigations which can be done. So the first one is skull X-ray, which is routinely ordered on any patient with craniocerebral trauma, which is also done to rule out the skull fracture. Then you move to CT scan. So CT scan is also done to determine craniocerebral trauma or injuries. Then the other one we see transcranial Doppler studies. So these are studies which are done to simply measure the blood flow and velocity. Remember, there is a danger of or risk of increased intracranial pressure. So it's very important that you measure cerebral blood flow and its velocity. Then the other one is neurological assessment. This will be done using Glasgow Coma Scale, as well as a full physical examination to simply identify bruises or to simply check if there are any fractures. Then on part C, they are asking for the management. So on management here, start with aims or objectives. So one of the objectives is simply to monitor the progress of the patient as well as to monitor the clear airway. The other objectives are simply to prevent complications such as hypostatic pneumonia, and the other complication can be to maintain good nutrition status of the patient. So under the management here, we are told to discuss it under medical and surgical treatment. So here we'll pick one and we are going to start with the medical treatment. So under medical treatment here, we are going to mention the following drugs which can be given. Number 1, antibiotics. So the main reason of giving antibiotics is simply to combat or to eradicate if there are any infections. And some of the drugs you can mention is benzyl penicillin 2 mega units, which can be given IV or IM 6 hourly for 5 days. You can also mention gentamicin 80 milligrams IM, which can be given 8 hourly for 5 days. So remember that from antibiotics, you can also go to diuretics. So diuretics here, these drugs will be given usually to treat or to overcome cerebral edema or to reduce cerebral edema as well as the intracranial pressure. So a good example of drugs you can mention is Lasix or furosemide, usually 20 milligrams IM daily for 3 days or whenever necessary. Then the other drugs you can mention is mannitol, 10 or 20% in 500 ml. So from there you can also mention analgesics. Now analgesics, these are drugs which will be given to simply relieve pain when the patient is fully conscious. Then good example is Panadol or paracetamol, 1000 milligrams 8 hourly orally for 3 days. Then from there you can also move to anticonvulsants. Now here you can give anticonvulsants like phenobarbital, usually between 30 to 120 milligrams daily. Or you can also give phenytoin, which is 15 milligrams per kg of body weight, and you can be given 5 milligrams maintenance dose. From anticonvulsant there you can move to corticosteroids or corticosteroids. These are drugs which you use to reduce inflammation. So corticosteroids here you can mention Dexa, which can be given between 4 to 10 milligrams IV 6 hourly. And you can also mention muscle relaxant or paralyzers. Now here you can give, for example, diazepam between 5 to 10 milligrams, and this is simply to prevent coughing and straining while the patient is on artificial ventilation. Then from there you can also give stool softeners like Colice, 100 milligrams orally for 8 hours or 8 hourly, usually to prevent straining as it may increase intracranial pressure. So from there you can move to surgical treatment. So on surgical treatment, depending on the patient's condition, the following procedures can be done. So if there is depressed bone, you can do craniotomy and bone elevation can be done. This will also help in draining blood or relieving or reducing increased intracranial pressure. And the other one is bowel, which is done to remove localized fluid or blood clots beneath the dural matter. So where there are open injury, you can also do debridement, which is done to prevent infection. So from surgical treatment, you can also move to nursing management or nursing treatment. So on nursing management or nursing treatment here, you begin with your aims. So here every nursing should have aims. So some of your aims you should consider is to make sure that your patient achieves healing as quickly as possible, as well as to restore rapidly the functions of all body organs, as well as to prevent complications like complications which may come as a result of fluid loss like hypovolemic shock. If it's there, to make sure that you treat it. Then from aims you move to primary assessment and resuscitation. Now under primary assessment and resuscitation, make sure that you begin with maintenance of airway. Now under maintenance of airway, this is where you make sure, or this is where you say, I will make sure that the airway is patent by positioning the patient in the recumbent with the head on side to promote drainage and prevent backfalling of the tongue while the patient is unconscious, or if the patient is unconscious or unstable. Okay, so if the patient is unconscious, you are going to say, I will make sure that the head is hyperextended to facilitate free entry and escape of air, therefore maintaining the patent or to prevent occlusion of the airway. Then if the patient is still unconscious, you can also install or insert the sterile oropharyngeal airway to prevent the tongue or epiglottis from falling back or to prevent the occlusion of the airway. Then in case of secretions, you are also going to say, I will suction excess oral secretion to simply keep the airway opened. Then from there, you move to maintenance of breathing patterns. So here we are going to say, I will observe for the adequacy of breathing by observing the respiratory rate, observing for the presence of cyanosis, and the use of pulse oximetry to check for oxygen circulation. So here you are also going to check for any general signs of respiratory distress, such as sweating, the use of axillary muscles of respiration and abdominal breathing to determine if there will be need for oxygen administration. So if need be, you are going to say, I will administer prescribed amount of oxygen to aid in breathing. Then you move to maintenance of circulation. Here you are going to say, I will check for any signs of hypovolemic shock or any signs of circulatory failure for necessary interventions, e.g. zero or low BP or increased pulse to simply prevent hypovolemic shock. Here we are going to also say, I will quickly check or access for patterns of the IV line for continuation or for administration or for easy cannulation and easy fluids administration. And here we are also going to say, I will administer prescribed amount of IV fluids to repress lost fluids and restore electrolytes imbalance, therefore maintaining normal blood volume. Then also on maintenance of circulation, we are going to say, using the fluid balance chart, I will also monitor the patient's fluid intake and output to avoid fluid overload and underload. Then you are also going to look at drugs. Here on drugs, we are going to give medication which will be necessary. For example, you are going to give drugs like painkillers or analgesics. You are also going to mention, for example, paracetamol. Then you are also going to mention drugs like benzylpenicillin to combat any infections, and you are also going to mention drugs, for example, anticonvulsants. So there are so many drugs you can mention here, as well as two softeners. These drugs are very important also to make sure that the patient does not strain, because this may increase intracranial pressure. So from drugs, you can now move to environment. So under environment here, you would want to make sure that you describe the area where the patient will be nursed from. So here we are going to say, I will nurse the patient near the sister's bay or in ICU equipped with emergency drugs or resuscitative devices such as oxygen machine for oxygen therapy, as well as suction machine for suction in case of excess oral secretions. So here you are going to also to say, I will also make sure that the room is warm enough to prevent hypothermia. And since the patients who are coming from theater are prone to hypothermia due to blood loss and exposure to coldness in theater, so here you are going to also say, I will make sure that the room is quiet to promote rest, and I will also make sure that the room is clean to prevent infection. Then from there, you can also move to position. Now, it's very important to take note of the position. So in subsequent care, nurse the patient in supine position with the head tilted on the side until the patient is fully conscious to simply promote drainage. Then change the position too early to prevent complications like bed sores. Then the patient gains consciousness. The patient will be nursed in semi-phallus position to reduce intracranial pressure unless contraindicated. So from position, you can now move to observation. On observation, there are a lot of things you can observe this patient for. So some of the things you can observe for the patient is the level of consciousness using the Glasgow Coma scale, and also observe for twitching or convulsions, and record if they are any or if they occur and report. And remember, anticonvulsants can be given in incidences where the patient show some signs of convulsions. So check vital signs as possible as 2-hourly or 4-hourly. This helps to monitor the functions of cerebrovascular system and respiratory system, including vital centers in the brain. Then here you observe for ear drainage of either blood or serous fluids, which may indicate that the meninges are injured or torn, and if the cerebrospinal fluid is escaping. So here again I'll mention it to say, make sure observe the ears for drainage, right? In case anything is coming out or serous fluid which may indicate meninges are injured or cerebrospinal fluid is escaping. So this will be done to control breathing in the ear. So to simply control this, you are going to say, to control breathing in the ears, I'll apply loose sterile cotton in the outer opening to simply absorb the fluid. This flows usually stops spontaneously. Then you are also going to say, I will observe fluid intake and output. And you are also making sure that you would want to observe the elimination patterns of the patient. Remember, the patient may be conscious or may not be conscious. So observe for the elimination patterns. So IV lines are also observed, and the catheter will be observed to ensure that they are functioning and draining well. Then you are also going to observe the nutrition status of the patient, which is very important because the patient may not be able to feed on their own. Then from there you can move to pain management. So pain management, here you can talk about diversional therapy. You can talk about administration of drugs in case the patient complains of pains. Therefore, you can give paracetamol 100 milligrams or even 75 or 750 milligrams of paracetamol. Then from there, you can talk about psychological care. So here you are going to explain all procedures to the patient, even if the patient are not fully conscious, to simply allay anxiety. Here we are also going to explain the condition and procedure done to the family members to simply allay anxiety. And when the patient is also fully awake, allow him to verbalize, then give appropriate feedback. So respond to the patient where you can. Okay. So you also need to assess for the psychological status of the patient to simply assist you in planning the interventions. Then ask the patient also and the relatives to express their worries and fears so that you can address the specific areas of concern, therefore allaying anxiety. Then explain the condition to the patient and the relatives or bedsiders in simple terms, okay, so that you empower them with knowledge, therefore allaying some anxieties. Then it's very important also to involve the client. So here you are going to say, I will involve the client and relatives in the care of the patient and explain all the procedures before even performing them. So from psychological care, you are also going to talk about rest. So it's very important to promote rest, as head injury is usually restless. So to promote rest, you are going to say the room must, or I will keep the room as quiet as possible by restricting traffic and the visitors. So here you are also going to say, I will also do constant observation quietly without disturbing the patient's resting. So here I also say, I will avoid sudden noise, flashes of light, and noise from equipment, which can increase the patient's restlessness. So make sure that all these are avoided. Sudden noise, flashes of light, noise from equipment. And also to relieve restlessness by slight change in position or relaxation of limbs or emptying of the bladder. So it's very important that you consider some points on resting. So from resting, it's very important that you also move to maintenance of good hygienic status. So here you are going to say, daily I will do bed bath to remove dirty and promote blood circulation and self-esteem. And you're also going to say, I will do oral care and health care whenever necessary to prevent infection and promote the patient's comfort. Here we are also going to say, I will keep the patient's beddings dry and clean to prevent infections or the formation of bed sores. So here you are also going to say, I will keep the environment clean and free from bad odors. Then you are going to move to elimination. On elimination, you are going to say, I will provide bed pine and urinal to the patient whenever necessary to help the patient in elimination. Then I will also observe elimination pattern and take note of abnormalities such as diarrhea, and if necessary or if they occur, I will take necessary interventions. Then you are going to say, I will encourage fluids intake to prevent constipation, as well as fluid intake and output on fluid balance chart to determine the level of hydration or dehydration. Then from there, you are going to move to part D, 5 possible complications of head injuries. So the first one is cerebral edema or hemorrhage. Okay, now this one usually leads to increased intracranial pressure, and this causes dysfunction of the brain because of the pressure which is exerted on the brain. The second one is herniation of the brain. Now the brain is usually displaced laterally or downwards through or against the rigid devices or structures of the skull. Therefore, herniation actually produces ischemia, infarction, or irreversible brain damage, and eventually it will cause brain death. So take note of this complication. Then the other one, it is injury to the blood vessels within the skull or the brain, which will reduce cerebral perfusion, and this causes hypoxia, ischemia, and permanent brain damage or tissue damage. The other complication which can be there is fluids, electrolytes, and nutritional imbalance. So the patient in the initial stage is not fully conscious and unable to take fluids and food orally. So this may lead to fluid and nutritional imbalances because they are not able to take food or fluids in initial stages. Then the other one is hypostatic pneumonia. Now hypostatic pneumonia, the patient may develop this because of being bedridden. Then the other one is urinary infection or septicemia. So this may develop due to the indwelling of catheter. Okay, so because of indwelling catheter, septicemia can be there due to the entry of infection through the open wounds or even fracture. Then take note of also this other complication, which is permanent physical or behavioral damage. So there may be permanent physical disability such as MA pressure and mental disturbances. The patient requires physiotherapy and rehabilitation. So these are the complications of head injury. So for now, this is where we end. This has been Mr. Divo. So subscribe for more YouTube videos and insights in nursing. So thank you for watching. Stay blessed.